Every nurse anesthesia resident will experience moments during their training that make them question themselves. A procedure doesn't go as planned, a patient doesn't respond the way you expected. You wonder if you made a mistake. But with the right mentor, these moments can become some of the most valuable learning experiences of your career. Today's guest shares how one unexpected clinical case, guided by an exceptional mentor, ultimately became a publication in the AANA Journal. Welcome back to the CRNA Mentor Podcast. I'm your host, Tyler Anderson, and I'm joined today by Dr. Jillian Moyer. Jill recently graduated from the University of Scranton's nurse anesthesia program this past May. During her training, I had the opportunity to get to know her both in the classroom as well as in the clinical setting, precepting her. And in today's episode, we're going to discuss her recently published case report in the AANA Journal titled Unilateral Spinal Anesthesia in a Repeat Cesarean Delivery, a Case Report. We'll talk about the rare clinical presentation itself, what it was like experiencing this as a nurse anesthesia resident, the mentorship that followed, and how an unexpected complication ultimately became a publication contributing to the field of nurse anesthesia literature. Welcome to the CRNA Mentor Podcast here, Jill.
Thanks for having me.
You're welcome. And congratulations on graduating. Congratulations on becoming a CRNA, and congratulations on this publication. It was something that was very unexpected on my end. I have the journal right here. So I got this in the mail and I open it up. I'm starting to leaf through it, sitting on my island. And I'm like, wait, this is Jill and this is Susie Newell. I'm like, one of my favorite students and an awesome, awesome leader in the AANA. So shortly after that, I texted you, but congratulations on the publication. That's unexpected.
Thank you. Yes, I was really looking forward to it for a long time. So I'm happy it finally came out.
Was it kind of under wraps from your end? Did any of your classmates know about it or anybody at the school?
I didn't really talk about it with many people. I did tell Zadok because we were keeping in touch about being at Moses Taylor because he was after me. So we shared a lot back and forth about what would happen at clinical and everything. But other than that, I didn't really tell anybody, not until probably the end of my senior year, because I presented the same topic for my DNP presentation. So then I kind of told people like, yeah, I'm actually going to be publishing the same topic here soon.
Excellent.
So.
Yeah. Excellent. Yeah. There's a lot of pieces to this story that we'll get into here shortly. But one of the things that I do want to mention as well on a personal note, 3 of my 4 children were born at Moses Taylor. So it's right down the road from me. And Susie Newell has really, completely changed the delivery of anesthesia care at that facility. So it's such a great opportunity for all of our students here to go to that site and experience what it's like to be in a CRNA-led hospital that is purely obstetrics. And I'm so excited for you to have this opportunity. And before we get into this, Jill, let's talk a little bit about your background, kind of where you're currently at in your CRNA journey and where you came from with school.
So I'm originally from Pottsville, Pennsylvania. I went to Waynesburg University for nursing school, and then I worked as an ICU nurse at UPMC in Pittsburgh. And then I moved home. I went to University of Scranton for school, graduated this May, and now I'm waiting to start at Lancaster General Hospital in August.
Excellent. Yeah, I know we had talked about this in clinical, but you're moving back home for me at LGH and around that area. And so it's super exciting to kind of see your journey. And I don't know if you've tuned into any of our other podcasts. We actually gave you a shout out a week or two ago with TD. We were talking about TD Carnahan, his intubation technique, and you're one of the people that are like, I got to try TD's nasal intubation, and those are things that as a preceptor really stand out with me. I feel that from what I've seen in your journey, and obviously, it's the classroom as well as clinical, is you're very motivated. And that's something that for all of our aspiring CRNAs to try and, put forth the effort, because we certainly notice it on our end as preceptors. Jill, tell me, when you were in anesthesia school and this case occurred, what was your experience like in obstetric anesthesia at the time? Where were you at, I guess, in schooling when this happened?
So I just started my senior year of anesthesia school. So I was completed technically almost one whole year of clinical at this point, but most of it was doing more of the what you would call basic cases, I guess, that
Yeah.
were junior level appropriate. But I did have some OB experience from one of my clinical sites earlier that year,
Mhm.
which I did maybe up to like 10 C-sections there. So I had a little
Nice.
taste of it, but definitely not proficient yet in OB. And
Hmm.
I had a few months since then before between doing OB cases. So
Yeah.
Moses was kind of like a fresh start again.
Yeah.
Uh, yeah, so.
Yeah, so it's interesting, and I always make this joke that when our nurse anesthesia residents are transitioning from junior to senior year, it's almost like they kind of whisper it. It's like I'm a senior now because they know the expectation is higher. They know that everybody in the room's like, oh, well, this is a senior student, so you should be running these cases, and I think that that's great. But when you get into this opportunity, you have this prior experience going into this. You go to Moses Taylor, and Moses Taylor in Scranton, Pennsylvania, is the baby hospital. Like if you're gonna have a baby, that's where you go to have that. And the care there that what Susie Newell has done has been tremendous. So let's get into this case report a little bit. Walk us through kind of from the beginning of the day. Was this your first case of the day, or how did this kind of play out for you?
Yeah, I think this might have been our only scheduled section for that day actually.
Mhm.
She was like a 32-year-old female. She was healthy, had a prior C-section with no issues before. So the only other thing was that we did have a language barrier. She was mostly Spanish speaking, which also makes a case more interesting, especially when you're having issues.
Sure.
But we brought her back. We had her sit up on the bed, all the usual things. I performed the spinal, went in perfect, easy, no issues with that. Had good CSF, felt really good about it. Had her lay down. We, had her on all the monitors, gave her all the usual medications, gave her some neo to treat like the usual drop in blood pressure, raising in heart rate. So for us, we're like, okay, good signs, everything's working. They're starting to get the patient prepped and draped, and per usual, they do the forceps pinch test, and that's when she wasn't really speaking to us at all, but
Hmm.
we noticed that she like winced, and we were
Sure.
like, oh, interesting. We're like, does that hurt? And when they pinched the left side, there was no response. And then when they would pinch the right side, she would wince. And we're like,
Hmm.
oh, we're like something's not right here. So that's when we
Yeah.
really started to deep dive, like having her try to move her legs and stuff. And that's when we were able to diagnose that she had a unilateral spinal.
Wow. And what was kind of going through your mind when you're watching her face? And I guess when we spoke about this before, I didn't realize the language barrier was there, and that adds a whole other layer to this case. Because this is one of the rare occasions when our patients are awake in anesthesia, right? And to have this inability to clearly articulate what is happening, and this entire experience, especially some individuals, in my experience, they tend to just kind of not say anything, and kind of, even if we have the language line there, even if we have the family members there that has signed off that they want to translate, they oftentimes just kind of, this is what this experience is supposed to be. And that certainly makes all of this more complex. Um, for our listeners, can you kind of describe exactly what a unilateral spinal is?
Yeah, so a unilateral spinal is when our anesthesia fails to provide like the sensory motor block on one side of the body, but it provides the complete sensory motor block on the other side. So they'll be able to move like one leg, they'll be able to feel what we're touching them on the one side of their belly, but then the other side's completely blocked.
Hmm. And there's several different differential diagnoses that go into this, but what did you guys come up with as what had likely happened in terms of what caused this unilateral spinal?
So we know, like with failures. Like there's three main causes, which it can be anatomical, it can be from technique, or it can be from your dosing. But for this instance, since it was completely one-sided, we were it leans more towards anatomic, because your spinal canal is a tube. So if you're putting anything in there, it should spread evenly around. There's nothing that should be blocking it. So it's not like we had positioning where she was laying on one side. We were trying to make it one-sided. It wasn't anything like that. She had the adequate elevation of the block to T4, so it wasn't the dose. And like we did have good CSF and everything, so we're like thinking like it probably wasn't a user problem, it wasn't a me problem, hopefully. So yeah, we were pretty much like, this probably is an anatomic barrier. Perhaps maybe the spinal before was a little bit traumatic, maybe from prior surgery, like there some things formed in there. It's hard to tell like what happens, but yeah, that's one of the causes, is anatomical changes.
And one of the things you mentioned there is it wasn't a me problem. And I do want to point out, and I will say, in kind of putting this episode together, and quite honestly, everything within CRNA Mentor and the CRNA Mentor podcast is always trying to look at it through the lens of our aspiring CRNAs, of our nurse anesthesia residents. And these failed spinals, they often feel very personal, especially in school. What do you think? What was your experience? Did you feel that it was like, oh, did I do something?
Yeah. So as soon as if I get a failed spinal, I immediately feel terrible. Like my heart sinks and I'm just like, oh my gosh, like what did I do wrong, or what could I have done better to make this like work for the patient? And like I've had it before with ortho cases, and a lot of times it's people like older populations, like their anatomy is all crazy from scoliosis and from prior back surgeries. And usually the CRNAs are like, it's fine. Like we can just slip them under, put an LMA in, it's fine. Don't worry about it. It happens. Or their anatomy's messed up anyways. It's fine. But I never had it happen with an OB patient. I've had it like that maybe it wasn't adequate enough that we had to give or they just like couldn't stand what they were feeling, even if it wasn't pain, and we had to give them a little bit of sedation to help them through it. But I never had like an actual failed spinal in OB. So for me, I was like, oh my gosh, like, are we gonna have to put them to sleep? And I never put I never put someone pregnant under general anesthesia. So for me, I was like, I know all the risks, and I was like, I will feel terrible if this is my fault. So.
Right. And I think that's something important to acknowledge. And I think as, learners, it's very quick, not only for the CRNA in the room, but for the rest of the staff to be like, oh, this is the student's fault. And especially in, an OB patient, because you and I know, and all of our aspiring CRNAs will learn, regional anesthesia, spinal anesthesia is the best for these patients, for the babies, for really every part of this procedure, for the mother to have a good experience and remember, the baby being born, right? So there's a lot that rides on this, and something that when you have that feeling of like, I did something wrong, it really can kind of throw you for a tizzy here in school and be like, wow, what just happened? But one of the things in our conversation leading up to this episode that you pointed out, you shared something that really stood out to me. You said that your preceptor, who was Susie Newell, she immediately assured you that this is not your fault. And can you kind of talk about, what happened in this moment and why this made such an impact on you?
Yeah. So, like you said, after we identified the failed spinal, everyone's looking at each other, like eyeing each other, like, oh, what do we do now? Like, we know something's wrong. And for me, it feels like everybody's looking at me because I'm the one that did the spinal, and I'm like, oh no.
Right.
Because a lot of times people don't like it delays the case, and then obviously it's an OB patient, so we don't want to put them under general anesthesia. But Susie literally grabbed me by the shoulders and looked me in the eyes and said, this is not your fault. And she's like, this is rare. It's kind of crazy that this is happening, but like, this is not your fault. And then she went around to the whole OR team and told them, like, this is not Jill's fault. Like, this is super rare. This is like an anatomical issue. She's like, this is so rare it could get published. And that's like what she said to everybody. And I think everybody like listens to her. They trust her. So like it was like the vibe in the room changed pretty quickly. So then it turned into like, okay, like what do we do now? And she like assured me like, we can fix this. Like, do not worry. Everything's gonna be okay. We can fix this.
Mm-hmm.
Yeah.
So, that experience, looking back, how did this kind of shape your understanding of what it's like to have great mentorship?
Well, it definitely inspires me to be more like her.
Mhm.
Because I've been in situations where I was thrown under the bus, like
Yes.
where
Yep.
they're like, "Oh, the student did that. It's her fault," or like an IV blows, even though I didn't put the IV in, it's the student's fault because she didn't double check it. Like,
Right.
so I'm pretty used to that, and I'm used to just taking the blame, even though it's not always my fault. Maybe I contribute, but to have someone not only like look me in the eyes and like be like, this is not your fault because she didn't want me to feel bad, but she like told all the staff too, because she
Mhm.
didn't want them to look at me like that, especially
Right.
because I feel like I was doing pretty good there. Like I was on a roll with my cases and I was feeling good about my skills. So
Yep.
it kind of just helped me get over that bump. Like,
Yep.
okay, this happens. Anesthesia is extremely humbling. And this is one of those
Yep.
examples. So she just kind of helped me keep my head up and keep going and make sure my reputation stayed intact there.
Yeah, no, that's such an important part. And really, I try my best throughout clinicals to try and ensure that people are having a good experience and trying to think about it from their perspective. But I do see, my colleagues, I do see, surgeons tearing into, some of our residents. I see anesthesiologists doing it. And it just creates a bad learning environment. And yeah, it's good that you got that great experience. Now, let's talk a little bit about, what happened after you realized, this is not working. What did you do next? What did you kind of have in your planning to proceed with this case?
Yeah, so for treating like the failed spinal, like we weighed our different options.
Mhm.
For some cases, like you can do a repeat spinal, but we ruled that out because she already had up to a T4 level on one side, and
Mhm.
then you have the risk of making that a complete spinal, and
Yeah.
then you're in trouble there. Or if there are true anatomical barriers, you might have the same result anyways. And then obviously general anesthesia is always our backup plan. But we were trying to avoid that as well since she is a pregnant mom and has a lot of more risks.
Mhm.
So then Susie was like, we can do an epidural, which I never would have like even thought of that like as a supplemental thing. So I was like, okay, like, yeah, let's do it. So that's when me and the OR nurse helped the patient like sit up, and Susie did the epidural record time, of course, and in like not the optimal position whatsoever, but she's amazing. So she put that in, and then we were able to like slowly titrate in lidocaine and fentanyl to help slowly bring that block up and to one side and try to do it safely so that we're not
Yeah.
getting a complete block. And
Mhm.
it ended up working perfectly.
That's great. What was your biggest kind of clinical lesson or takeaway from this entire experience?
I would say my biggest takeaway would be like knowing what my options are. And because I feel like we know the recipe for what we're supposed to do every day for these cases, but what we're really like paid to know and educated for is what to do when those things aren't working or when
Yeah.
something's not going right. So like knowing what my options are for those rare situations, like for that case, and then sticking with what I think is the best for the patient,
Right.
because I know like many other places would have just switched right to general anesthesia
Yep.
because they know how to do that and they know that that will work. But I think it's important to know what's still best for the patient that you can do as long as time is allowing. Obviously, sometimes it's more urgent and you have to work quicker. But if you have the time, then we should be patient. And as long as the team is understanding, you can try different things like an epidural because it is better for the patient. So I think it's important just to be able to stand your ground and advocate for that.
Yeah, and that's something that you really kind of touched on in our conversation leading up to this podcast. And oftentimes we get so focused on the technical management of these cases, and we don't really focus on the advocacy part as much. And as you mentioned, like this experience, and I think we need to think about the birth of this baby as an entire experience for this patient. How can we optimize it, and how can we do something that is safe as well as the best outcome for her? And yeah, I think that's really important to key in on, and especially as all of our aspiring CRNAs are going through this process, as our nurse anesthesia residents are having these experiences, to kind of keep that in the forefront of your mind, because it's so easy to get caught up in the technical side of things. Jill, at what point did Susie kind of say we should publish this, and what was your reaction to that?
So she like mentioned it like when we were kind of figuring out what was going on, because of like she identified it right away. Like, this is rare. Like, this
Yeah.
isn't something that happens often, especially to this level.
Right.
And then after we did the epidural and it worked beautifully, she's like, we should publish this. Like, because she kind of did another reassurance for me after the case, like, hey, let's talk about this quick. Like, this happened. It was like, we got through it. It was not your fault, but like, look at the outcome that we had. And then she's like, we should publish this because this is rare. There's not a lot of literature on it. And like, it's important for us to publish cases like this so that there can be literature on it in the future. And she's like, this way people might know what to do if they come across this as well. So at that point, she was like, let's do this. And I was like, all right, like, yeah, let's do it. So that kind of got the ball rolling. And then she like worked on it, and we got through it like really fast, actually, because she's done it before, so she knows what to do, which is really impressive to see.
Yeah, that's why Susie was the clinical educator of the year within the AANA.
Oh, for sure.
She's great. Can you walk us through the publication process, and what kind of surprised you along the way?
Yeah, so first biggest thing, I guess, is making sure you have like IRB approval if you need it, and consent from the patient. For this case, doesn't really require much because it's just a case report. But then it's more of just gathering all the data, and then the literature that you can find on it, which this, again, not a lot of literature to support it. A lot of it's just like general information, and then we're trying to put in our 2 cents of what we discovered. But then it was just making the manuscript, and then submitting that, and they make sure that it's appropriate for the journal. They make sure it's ethical and lines up with their views and everything. And then if they like it, then they will submit it for peer review. And then the peer review part I thought was really interesting, because they literally will like label everything, this line for this paragraph, and like say, okay, like, this is what you said, this is what I think needs fixed. And then when you respond, you have to say exactly how you address each thing that they mention, which I was like, wow, that's like pretty intense.
Right. Yep.
Yeah. So after you do all of that and send that back, then you can, I think they send you like the revised copy or whatever. They like format it, they do their edits. You have to make sure everything's in AMA, which is completely different than I'm ever used to, AMA format. And then they'll send it to you for like a final review. Both authors will approve it, and then they'll like say, okay, we're going to publish this in this month of the journal.
So all in the process, was it about a year for you?
Yep, about a year, because this happened in July and then it published in June.
Wow. How did you manage all of that? I mean, you're in your senior year. Obviously, you were done with your didactic portion, I think, at that point, right?
Yeah.
But this is still a lot. I guess it was Susie kind of your resource throughout all this process.
Yeah, Susie was amazing. She took like the main toll of it. She's done everything before. She like was guiding me through it, keeping me updated with like the emails of everything. Because if I was doing this by myself, it would probably took me a century to figure it all out and go through everything, especially with clinical and studying for the C exams and so on. It would have felt like impossible for me to do. But she was a rock star with that, and she just kind of was like, okay, this is what's next. This is what we have to do. I'm going to send this to them now, and so on. So she was like a really good liaison with all of that.
That's excellent. It really sounds like, publishing this article didn't just kind of give you a publication. It kind of changed the way that you thought clinically, right? You were talking in our phone call about looking into another research idea involving intrathecal fentanyl for C-sections. What kind of sparked your curiosity with that? And what did you learn from trying to pursue that project?
So, after being at Moses Taylor, I kind of realized how much I love obstetrics, and I felt very passionate about it and like protecting that population because it is such a vulnerable population. And I feel like a lot of people don't like doing OB, and it probably depends on where you're at in the culture with it. Sure. But a lot of people don't like it, and so I was like, I like it, and I would like to protect it. And when I was at my next clinical site, I would go up for the C-section. They didn't have it nearly as many, but I would go up every once in a while when I could. And I realized like they weren't putting any fentanyl into their spinals. It was pretty much only Duromorph. And we were end up sedating most of our patients because they were in so much pain. And I looked into like the literature on it. I knew what I did at Moses. I knew what I did at the other clinical site. And we always put fentanyl and Duromorph in there. So I looked into the literature, and it really supports, like, yes, fentanyl is good. It helps with the onset of action, and also helps with the depth of the block to cover the whole uterus. Because the Duromorph obviously is more for post-op. It works later. And then the fentanyl works now, and it really gets in there into the uterus, because I feel like the local anesthetic works more superficially, and it gets them through the cutting and through the initial birth. But then once they start suturing the uterus, it feels like it goes downhill from there. They can't handle it. They start screaming, crying, and then they're inconsolable. They can't enjoy being with their baby. So it really, like, I felt horrible every day. And I don't really have a say because I'm a student. So I'm like, all right, like, here we go again. And then I'd make sure I had my Precedex, Versed, ketamine, everything ready to go if I needed it, because it was just seemed to be happening every single time. So I started to look into, like, maybe I can do a quality improvement project here, and do like a retrospective cohort study to show, like, hey, look at this. Like, these few patients got fentanyl and Duromorph and they did wonderfully. They didn't get sedation, versus all these other patients that you only gave Duromorph and they required all this extra stuff. Like, it almost became normal for their anesthesia to just expect to give sedation. And I was like, that's not okay. Like, that's not normal. That shouldn't be expected. So I really wanted to do that. But then through the process, it took me a while to get IRB approval from the hospital. I didn't need IRB approval from the school, because they accepted the hospital one. And then I also got like a mentor from my school as a professor. And then I got the head anesthesiologist there to support me as well. So then the hard part was getting access to the information. And I called so many people, I emailed so many people, and it was a struggle for them to try to give me any access. So in the long run, months later, I ended up never getting access.
Yeah.
So,
well, I mean, it's impressive. Was that then after this initial experience at Moses Taylor?
Yes. Yeah.
Yeah. So you're plenty busy in your senior year, but looking for all these other opportunities.
Yeah.
Jill, I want to kind of help, provide some advice from other nurse anesthesia residents that are going down this path. And I think that many of them don't realize how many opportunities for growth exist if they just simply pay attention to these opportunities. And I think I kind of want to talk about, what advice would you give to nurse anesthesia residents or SRNAs who encounter these unusual or kind of unexpected clinical cases during training?
I think it's important to look into them. We do like case studies every semester, and I feel like I learned how to find like these interesting cases where things were like different or went unexpected, or things that I thought could change. And I would use that to deep dive into a literature review and like find things and realize like what I probably will do in my practice in the future to help make that better for the patients, and to have like better outcomes and everything. So I think it's important to stay up to date with literature, but like make sure you keep deep diving into it to explore things. Like don't just be status quo, like this is how we always do things, because everything's always changing, medicine's changing, and there's always more literature coming out to support changes in practice. So I think
Mhm.
it's just important to do your own research and not just trust like the old ways or how everybody else does things, and then figure it out for yourself.
Yeah, no, that's good. And one of the things I do want to mention real quick, in our phone call, you kind of brought up a story, and I think when people are listening to this episode, aspiring CRNAs, nurse anesthesia residents, and they're like, research is not quite for me. This whole process is intimidating. On the phone, you're telling me about your experience when the school had brought in, this IRB point person to talk to your class. What was going through your mind during that presentation? And when was that? I guess that when that person with the IRB came in.
They usually the she came. I feel like I heard her twice, so it was
Okay.
during like our M&M thing. So it would have been either the end of our freshman year or like our in our second year.
Okay.
She came through, but like she was just like the IRB lady. They're like, yeah, the IRB lady's coming from the school to talk to us, and we'd all be like, oh, this we have to do this again. But yeah, running through my mind, I'm like, yeah, I'm never gonna do this. I have no interest in research. I don't want any part of this, so I don't really need to
Yeah.
pay attention. And then as soon as like we I did this with Susie, I was like, this was actually really cool. Like I felt like I learned a lot. I feel like this could help others
Yeah.
and can express like what I'm passionate about. So I was like, huh, maybe I should have paid attention. And then when was thinking about doing that other research, I was like, Tracy, what's that IRB lady's name again? Like I need to reach out. But yeah,
Mhm.
so I definitely changed my point of view going through school, and now I'm like, okay, I definitely would be interested in doing this again, if like the proper opportunity came up.
Yeah, that's that's really probably one of the biggest takeaways for everyone listening to this episode is the more receptive you can be to these opportunities. There's going to be multiple doors that are going to open for you. There's going to be individuals like Susie at your clinical sites that are going to be like, "Come on, I'm going to show you the way." It's going to be more work. Don't get me wrong about that, but it can be an amazing opportunity that can completely change your mindset as you navigate this path to CRNA school and becoming a CRNA. And props to you for jumping at this opportunity, and props to Susie for helping kind of facilitate that. But don't shy away from these experiences, even if they are more work. I think that's probably one of the biggest takeaways from this episode. As we wrap this up, Jill, I want to zoom out a little bit and just away from this one case and kind of look at the bigger picture. As you begin your career as a CRNA, what lessons from this experience do you think you'll carry with you throughout your career?
I think that I will carry with me, like I said before, like advocacy, like not being afraid to do what I think is right for the patient and what's best. I feel like this experience gave me more of a backbone, for advocating for patients,
Mhm.
especially in the OB population. Like, sure, if I'm in a robotic lap chole and I want to give them Precedex or something, and the anesthesiologist is like, no, I don't like that, I can probably like let that battle go. But when it comes to OB and like, if I think they need fentanyl in their spinal, or if I want to try an epidural to supplement like the failed spinal, I feel very comfortable like pushing for that now, because I've seen all the research on it. So I think I'm going to be much better at speaking up for that.
That's great. Jill, congratulations again on graduating from the University of Scranton, on becoming a CRNA and publishing your work in the AANA Journal. Also, a little plug, thank you you helped represent University of Scranton at the College Bowl at PANA, right? And
Yes.
This was our second win here in the history of the school of winning College Bowl. So thank you for being a part of that and making all of us alumni proud. These are really incredible accomplishments, and I really appreciate you taking the time to share this story with us today. One of the biggest takeaways from this episode and this conversation is that your journey through CRNA school is much more than learning about how to perform anesthetics. It's about how to think through these unpredictable and unexpected situations, about advocating for your patients and really growing from these challenges and seeking out these mentors who help make you the best provider that you can be. So for all those listening today who are aspiring CRNAs, who are nurse anesthesia residents, the patient that you're caring for today, the case that doesn't go according to plan, or the mentor that's investing in your development may end up shaping your career in ways that you never expected. So thank you for joining me today. If you guys found this episode helpful, I really appreciate if you share with somebody who needs to hear it, who is another aspiring CRNA. And Jill, thank you again for joining us and for being part of the CRNA Mentor platform and just sharing your wisdom, and good luck moving forward here.
Thank you.
All right. Take care, Jill.
You too.